So I'll be, thanks for the invitation, and I'll be talking on acute comitant esotropia, investigations and management. So to begin with, we all should understand that it's a very rare type of strabismus in 0.3% of children. It's characterized by acute onset, large angle. Initially, it may be intermittent and then comes to constancy. And usually, it is present in older children and adults. So many people with acute onset of esotropia have uncorrected myopia, and there is oftentimes associated with excessive near activity. So we noticed that there is a decompensated esophoria in few people. So initially, they may have progressive, intermittent, horizontal or binocular diplopia that then dramatically converts into a constant large angle esotropia. Sometimes it can also be associated with intracranial diseases like brain gliomas or Arnold-Chiari malformations, and these could be etiologies. So the etiology is still not completely understood, but it can be associated with excessive near work, which could produce an imbalance of convergence and divergence tone of the extraocular muscles. So the classification initially was given by Swan et al. Into 3 types, and this is the most comprehensive classification by Buck et al., where type 1 is the same as Swan's, occlusion related. Like some patients, say that they do occlusion and then they notice esotropia once they remove the cover. Type 2 is the Burien-Franchetti type, which is non-accommodative, precipitated by physical or psychological stress. Type 3 is the acute comitant, sometimes associated with hyperopia, and we can control this by wearing glasses. Type 4 is a decompensated ACE, monofixation syndrome or ESO. Type 5 is associated with intracranial pathologies. Type 6 is cyclic ACE, and type 7 is the secondary ACE. So now in the recent 5 years, we have noticed an increased incidence of ACE all over India. And this ACE related to COVID era does not usually meet the diagnostic criteria for the 3 main types. Most of the patients, it's associated with a smartphone usage of more than 4 hours a day. And everybody who uses smartphones does not face this problem. So it mainly occurs in adolescents who have a low divergence capacity or a previous latent esophoria. And that leads to a dramatic overaction of medial rectus, and that results in the manifestropias. So this was a study which was published where they compared the incidence of ACE to IXT from the years 2007 to 2021. So here you can see that the proportion of ACE to IXT has comparatively increased from 0 in 2007 to 5.88 in 2021. So that in children, it leads to amblyopia. The longer you wait with this misalignment, it can lead to amblyopia, where in adults, it leads to intractable diplopia, which was so beautifully illustrated by the previous speaker. This was a recent study published in JPOS 2023, where they talk about the clinical profile of around 338 patients diagnosed with ACE. The mean age in children was 3 and adults was 26.6. There was significantly more number of individuals with myopia in the adult onset group, and a total of 148 patients underwent surgery. The success rate in surgery was 73%, and success was better in the adult onset group, that is 75 to 66% in the childhood onset group, and they had followed these patients for around 12 months. So regarding the history and evaluation, we should note down the type of diplopia, the onset, that history regarding the hours of near activity, the duration of symptoms. Always better to look at photographic evidence before the said period of onset to see whether it's constant or intermittent. Orthoptic evaluation, including motor and sensory. Always see the ability of the patient to fuse with the prisms, because that will give an idea of the post-operative outcome that you may expect. And always rule out accommodative esotropia by cycloretinoscopy and prescribe glasses if so. So the criteria, as already stated, is acute onset with a comitant deviation. Comitant means there should be no difference in all the cases, and between near and distance there should be no disparity. You get a photographic evidence. Most of the patients have smartphones. You can actually see the period where it has started, and normal motility with diplopia. Imaging, better to do in all patients because rarely it can be associated with intracranial etiologies. So the natural history, spontaneous recovery is unusual, but you can always advise the patient to stop all the near activity for a short period and observe. And there is excellent prognosis for binocularity if you intervene early. Differential diagnosis for this condition is acute 6-nerve palsies, divergent related distance esotropias or divergence palsies, accommodative esotropia. In all these conditions, you will find a near distance disparity, ocular myasthenia, and decompensated monofixation. So treatment, there are various treatments for ACE, including extraocular muscle surgery, botulinum toxin injections, prisms, and divergence training. But the gap between the onset of the double vision and the diagnosis and your treatment strongly influences the treatment outcome. So the main factors that determine a good motor and sensory results are good visual acuity at the time of diagnosis, younger age, and augmented surgery dosage. Whenever you plan for surgery, aim for a small exophoria because that will make sure that you do not, the patient do not have diplopia postoperatively. Coming to the role of botulinum toxin, it can have many advantages being less invasive. It's a non-surgical option. It results in faster recovery, and you can do this very early, like 1 month post onset of symptoms, whereas for surgery you may need to wait a little longer, especially in cases where you do not have stable measurements. So we have significant experience with Botox in our center, where the dose-related injection, the units depend upon the angle that we measure, and this is being injected under very short inhalational anesthesia in children and topical in adults, so it is like a OPD procedure. And in 47 patients that I have injected, a mean age of 10, you can see that many of them were presented less than the age of 5. About 90% had no systemic associations, and 51% of the patients had presented within 1 month of onset. And this was the dose. Most of them had a large and stable angle around 40 prisms. And if we see the success rate, if you quantify as final horizontal deviation of less than 8 prisms of ESO with diplopia relief, then we had success in around 59.57% in the 9-month follow-up with a single injection. And if we consider just as release absence of diplopia, then we achieved success in 79.5% of patients at 3-month follow-up visit. And so it is less invasive, faster recovery, good option in variable angle, cost effective, and most of them, once they get them realigned, then they don't fall back into the esotropia. And post-operatively, post-injection, you also need to work on their divergence. You need to put them on exercises to improve their divergence abilities. So this was a study which was comparing with surgery as success less than 8 prisms and sensory outcome stereo of 40 to 60. They found around 60 to 70% efficacy, and similarly another recent study in August 2023 compared between botulinum toxin and surgery, and in their experience they had found about 73% success rate in the botulinum toxin group versus 97% for the surgery group. So that's all I have to say. Thank you.
Thank you, Dr. Sandra. That's a wonderfully detailed talk on AAC. And Dr. Jetani tells me that all this is being recorded and it will be available on YouTube. If you want to refer in the future, I think it will be an excellent resource. Thank you so much for that comprehensive talk. And